Okay, how's it going, guys? I hope everyone is well today. We just pulled up to the SSISA, which is the Sports Science Institute of South Africa. We're a little bit early, but we're going to head inside now, and yeah, we're going to go through a couple of things. We're going to check I got my blood tested a couple of days ago, so they're going to go through everything and just interpret it for me. Um, and then stay tuned because we're going to sit down, Grant and I, and just go through pretty much the full panel and check everything else out. Grant, what else are they doing?
ECG, electrocardiogram, and also spirometry, so lung function and heart function.
Cool. Yeah. Stay tuned. We'll bring it to you guys now.
I don't remember.
Cool. Morning, Big G.
Morning.
How are you?
Cool in here, man.
Good. I'm feeling great today, actually.
Oh, that's excellent.
Yeah. It's been a while. So.
Yeah. That's good, bro. I'm really happy for you.
Yeah. So welcome, guys. Sadly, a little bit of a disappointing news. We are only getting our results back on Monday. So just for us to check through the results from the doc. So that's all the bloods, that's the ECG graphs, etc. So we are going to talk a little bit about that in this episode, but the full panel and the really interesting stuff will probably come next episode. We're going to speak about some of the findings that we had, some of the abnormal things, or kind of normal but abnormal, the interesting things, I should say.
Interesting things, yes. And we're going to plug up a couple of things just from last week's video. And welcome. And we're going to chat about that, and definitely we'll get deep into your stuff.
Yeah.
So how are you feeling?
I feel good. I feel my mind is feeling great after the results. It's obviously something to say about like not quite knowing if you are healthy. I've been feeling fine, but just to get the results and the word from the doc that everything's fine. It's skiff. I feel relieved in a sense, and I feel good.
Good.
I feel ready to train, to be honest.
Yeah. So essentially, we got a clean bill of health. From the doctor, except for some under stress, and it's common with athletes, and we're going to go into it, something called a premature ventricular contraction, which belongs to a group of things called ectopic beats. Ectopic just means out of place. Like you get an ectopic pregnancy with the fetus starts developing in a fallopian tube. Yeah, and it's ectopic. In other words, it's out of place.
Out of place. Yeah.
So an ectopic beat is something that is just a beat that's out of place in your. So your heart's like the doctor described to you. We're looking at the heart now. So the whole point of an electrocardiograph or electrocardiogram is to look at the heart's electrical conduction system. So your heart generates its own electricity. It's known as its intrinsic conduction system. And it's got a pathway that it usually follows. It starts with your pacemaker or your SA node in the right atrium, the top up right-hand side of your heart, which depolarizes. Depolarize just means sending energy. It's stored energy. It's when it polarizes, it stores that energy. When it depolarizes, sends it off. So
discharges.
So exactly, it discharges or depolarizes along a pathway down to your atrioventricular node, so AV. So the AV node, atrioventricular, tells you that it's separating the ventricles, which is the bottom chambers of the heart, from the atria. It hits the AV node. There's a slight pause there or a slight delay that you can see on the ECG. And then what happens is it is passed through to the ventricles. It travels down the Purkinje fiber, or the bundle of his, to what's known as the Purkinje fibers, as far as I remember, and then those depolarize, boom, and that gives your heart a contraction, lets blood travel from your heart. Now, the key here is that every single cell in your heart has the ability to generate its own electricity. So what happens is, like you, and we're going to get into the studies, it's common with athletes. And what happens is you get an ectopic beat, or one of those, your heart's normally carrying on how it should, and then just one cell or a couple of cells somewhere in your ventricles, if it's ventricular, or somewhere in the atria, if it's atrial, because you get atrial contractions and ventricular contractions. Yeah. So if it happens in the ventricle, say, for example, it's just a group or a little bunch of hyperexcited cells, and they just kick in, just like that. There can be a phenomenon where these are actually rescue beats or escape beats, and that is when, for some reason, they're actually assisting your heart. So there can be, so when you're treating these things, so PVCs can be dangerous, they can be abnormal, and it's usually when there's long strings of them, when they've got different morphology, like you saw yours had one type of morphology, it just looked like the same. If they look very different, then that's another warning sign. If they're long strings of them, and if there's something called RNT phenomena, so if one of those PVCs happens on the T wave in your, as you see in the ECG, which is when your ventricles are under repolarization, then that can be dangerous. There's something it's called commotio cordis, and it's, if I hit you in your chest, it happens to a couple of sportsmen players every year. You get a knock to your chest at a certain point in your cardiac cycle, where actually during ventricular repolarization, which is represented by the T wave on the ECG. If you hit somebody in their chest right at that point, it causes ventricular cardiac arrest, VFib. The heart's electricity is going everywhere, and the treatment is immediate defibrillation, right? So the PVCs that the
just something. Those, how do I say it correctly? Ectopic. So I could actually feel them. And it was something that went on for a little while. I got a scare, must have been like a year and a half back or something, when my heart, or when I was just under stress and my heart rate goes up, and I get those ectopic beats. It's almost as if like I skip a beat, and then it just, you wait half a second and one comes back harder.
And that
and
can happen. You can actually be skipping a beat, and then that PVC is the escape beat or the rescue beat that comes in and rescues your heart. Can be something. So we look at when pre-hospitally, right? Say, or in emergency care, where I get sent to a patient, we don't know what's wrong with them. I put on an ECG and I see PVCs, right? And I decide they're dangerous, and I want to now I want to decide whether they're dangerous or not. The thing I go on is patient stability. If the patient's stable, i.e. normal blood pressure, normal level of consciousness, all the rest of it, no chest pain, etc., no pulmonary edema, so that's just a sign of something, instability with something going wrong with the heart or the cardiovascular system, so you get fluid build up in your lungs, heart failure. If I see those PVCs and I have to decide, if the patient's stable, I don't treat them. Because if I treat them, it's going to suppress them, and then it's actually going to harm the patient, because I'm suppressing that patient's rescue beats or escape beats, which is that patient's heart's mechanism of saving itself, basically, right? So if the patient's unstable,
staying in rhythm.
If the patient's unstable, so decreased level of consciousness, chest pain, low blood pressure, pulmonary edema, so it sounds like they are breathing through a whole bunch of foam, like fluid-filled lungs, then we go ahead and we treat them. And we suppress those PVCs. So this ectopic beats is an interesting thing. So the bottom line is what the doctor said is they're usually benign. It looks benign to him, but he still wanted to refer Cole onto a cardiologist. And the cardiologist will perform a different set of examinations. Cardiologists, obviously, they can do a whole bunch of things with regard to that. But probably the first thing they'll do is do the ECG. They might do a different type of ECG. They might look at the right-hand side of your heart. They might look at the posterior back end of your heart. Then they might do bloods. Again, looking for certain markers, like we chatted a little bit about brain natriuretic peptide, or BNP, and ANP, atrial natriuretic peptide, which is basically hormones that are released when your heart is under too much strain. It's called Frank Starling's law of the heart. We won't get it into now. It's got to do with the whole stretch of the heart. Anyway, Starling's law of the heart, as far as I can remember, but
Future episodes,
yeah. But essentially said it was benign. So what I did is I've pulled up a whole bunch of studies on ECG, on premature or PVCs that you're going to see, and we can start chatting a bit about them. Something that I just wanted to clear up from in our last episode, I think I got a bit tongue-tied. So basically, I just wanted to start by saying, what is the American Heart Association? Why do we really look at it so much? Because I'm always referring back to them. So about us, they say for nearly 100 years, we've been fighting heart disease and stroke, striving to save and improve lives. So basically, it says 6 cardiologists founded the American Heart Association in 1924. And it's grown into the US, or the nation's oldest and largest voluntary organization, dedicated to fighting heart disease and stroke, and a shared focus on cardiovascular health unites more than 35 million volunteers and supporters, as well as our more than 2,900 employees. We look to them for guidelines. We look to them, they're a body that we follow, that we look to them for all our guidelines for cardiovascular stuff in this country, and including the treatment thereof.
We did have a link in the last episode, but we'll pop it in the description again for you.
I just think I gave a bit of a wishy-washy, not a good basically description of who they are and why we follow them. In any event, the American Heart Association, we look back to them, and I see that they, in one of their studies here, they've got a study from AHA journals. So there's American Heart Association journals with studies. And this study is called Evaluation and Management of Premature Ventricular Complexes. There's another study that I pulled up here on just premature ventricular contraction, actually just the National Library of Medicine, basically an abstract from a page. But I do have a very interesting study here called Ventricular Ectopy, which is what you have, as a predictor of heart failure and death, which is quite an interesting study to look at. And that comes from the Journal of the American College of Cardiology. So, just to chat about PVCs, so we'll show you in the next episode really nice. We'll actually bring up a
study for you guys,
and show you what it is, and we'll also get into we'll show what a normal ECG is. So when you look at the ECG, you have those things that QRS complex. So you see activity, and then a gap, and then activity. Each one of those activities that you see, we'll go into nice. I'm just trying to give it in layman's terms. Each one of those bits of squiggly lines that you see represents the heart doing something. Depolarizing electricity and then repolarizing electricity. And we chatted before about something called Einthoven's triangle. So you make this thing, when you put those electrodes on the heart like this, lead 1, lead 2, and lead 3. 1, 2, 3.
Yo, I had a bunch of leads on me for the...
You had a 12-lead ECG.
12 lead,
so we look at 12 leads. It's
Bionicle
10 cables.
on that bike,
10 cables, 12 leads. So every time your heart goes through this process of depolarizing this electricity, it sends vectors out. It's electricity moving out. And then what happens is you capture that with the ECG using Einthoven's triangle. So you're basically making a big connection circle around the heart.
Collecting the pulses.
Same as what the Apple Watch does. I'm getting Cole an Apple Watch at some stage so we can see under strain and it was not in his resting ECG, it was in his stress ECG, which I put him on an exercise bike. And it is common with athletes. Now you've got the whole hyperactive or excited myocardium is all excited, and then PVCs are common.
Did I have any ectopic beats on the rested ECG?
No,
one?
No, nothing.
Okay.
It was so it's common with athletes, right? It says here, so this comes from the American Heart Association. This is Evaluation and Management of Premature Ventricular Complexes. So it says here, abstract PVCs are extremely common, found in the majority of individuals undergoing long-term ambulatory monitoring. Increased age, a taller height, a higher blood pressure, a history of heart disease, performance of less physical activity, and smoking each predict a greater PVC frequency. Although the fundamental causes of PVCs remain largely unknown, potential mechanisms for any given PVC include triggered activity, automaticity, and re-entry. Re-entry is an advanced concept, and we won't get into it right now, but it is important for understanding arrhythmias. We'll get into different arrhythmias at some stage.
Yeah, for sure.
So the history, physical examination, and 12-lead ECG are each critical to the diagnosis and evaluation of a PVC. An echocardiogram, which is a sonar of your heart, that's what the cardiologist will do for you, is indicated in the presence of symptoms or particularly frequent PVCs. So they counted 5 with you under strain. And cardiac magnetic resonance or MRI imaging is helpful when the evaluation suggests the presence of associated structural disease, which is not the case with you. That would be like complex ectopy in different directions and all kinds of things going on, multiple focal points. If the complex looks exactly the same, it's the same point that's making it. But if there's different points, each making PVCs, then that's dangerous.
That's dangerous.
And you'll see that by they look different on the ECG. Again, dangerous if you're unstable. If it's stable, then
what would the sonar scan tell us that the ECG can't? A lot more, is it?
That's very interesting. So what the sonar scan will do is the sonar is able to look at where blood's actually moving inside the heart. So you'll be able to see what's happening with the valves and you'll be able to see like what your ejection fraction is, how much the cardiologist will see blood. It'll see your heart filling up again and see your heart contracting. But specifically the diagnostic criteria, I don't know.
Okay.
But we'll get into that. That's a very, very good question. Maybe we want to make a note of it somewhere, and we'll see what we'll do that. We'll look for the studies. The cardiologist is the perfect person
to ask that.
To ask that question to, yeah. So let's just, it goes into prevalence, predictors, mechanisms, evaluation. So let's talk about evaluation for a second. Patients with PVCs typically come into clinical attention for one of two reasons. The symptoms are an incidental finding on a medical examination, in your case, or the symptoms may induce palpitations, which is what you felt, which may manifest as chest discomfort, as sensation of intermittently strong heartbeat, which is exactly what you had. Do you want to describe what you had?
I kind of did. It was
you did it, eh?
like under stress. It felt like I skipped the beat, and I would have a couple hard ones, and it would rattle me. My whole body would just like.
I've experienced it before, and we're both.
It's concerning.
And you know the thing
when you don't know what it is, it's really concerning. You're like,
and
damn, am I gonna?
Yeah. The thing about both of us is we've both been exercising our whole life.
Yeah.
Both of us did sports the whole way through school. Then we both did extreme sports. So we both picked up skateboarding. You went a bit more extreme than I did with the downhill, but we've always been active. If there's something about me, I've always been active.
Yeah.
And they get into the fact that it's common with athletes.
Yeah.
So
downhill skating is you're stuck on a hill for like 6 hours.
Yes.
Probably go up and down like 150 times for 100 runs or something.
Yeah, and I've always been under load as well. So and we both experienced it. So in any event, it says, okay, they talk about the symptom is not often attributable to the PVC itself, but rather the sensation of the particularly strong heartbeat that occurs because of the prolonged ventricular filling time after that PVC, resulting in an enhanced stroke volume, which is the amount of the amount of blood that's leaving your heart, I think in a minute, as far as I remember, along the Frank-Starling curve. Remember, we said Frank-Starling's law of the heart, and potentiated calcium release. All these things are governed by electrolytes in your heart. So in your heart, you have fast sodium channels and slow calcium channels. So sodium channels are all over your heart. I think calcium channels are only supraventricular or ventricular, but I can just look at it. But interestingly for you guys, remember that it's electrolytes that are actually doing this, that's making this electrical potential happen. So let me just see it. Fast sodium channels of the heart, fast sodium channels of the heart, fast sodium channels of the heart. I just want to make sure that I'm right, guys. If I'm wrong, we'll put it in the we'll fix it. But just talking about it, So it's a class of drugs. Okay, so blockade of sodium channels slows rate and amplitude of blah 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 blah. What are the fast sodium channels? Sodium channels mediate fast depolarization and contract. I'm just trying to remember where okay. So we know that, for example, lignocaine is a sodium channel blocker. So lignocaine works only in the ventricles. I think that calcium is supraventricular. And
is that a medication?
No. So calcium is inside your body. You've got electrolytes. You've got sodium, potassium. Potassium is intracellular, right? It's not meant to be like free in your bloodstream. Okay. So, but they're all important. Your human body, when you break it down, the basics to how it works, everything is all got to do with electrolytes. Yeah. So the important ones, you have anions and cations. You have positive ions and negative ions. So the positive ones are sodium, calcium, potassium, and there are a few others. Negative ones is like chloride and so on. But they're all these. So sodium works. Your nervous system works on sodium, and so does your ventricles of your heart. Right? Calcium, as far as I remember, I don't remember exactly. I think calcium is only in the atria, but a little bit in the ventricles. But this is all happening due to fast sodium channels and slow calcium channels in your heart, and it's all the movement of electrolytes in and out of the cells that's causing this electrical activity to actually happen in your heart. We'll put it in the description and also in the video. I can't remember exactly, and not really getting good answers here. Researching, but I'll have to do some specific research and just get back to you with regard to where sodium and calcium where in the heart it's happening, right? But essentially, there's two classes of antiarrhythmic drugs that we use. pre-hospital in any event. One is lignocaine. So lignocaine is a sodium channel block, and it works on the ventricles.
That's what I was. That's my previous question. Is that a medication? So
Yes,
that's
lignocaine. Yeah, you use it. So lignocaine is the treatment for PVCs that are dangerous, right?
Okay.
So, and because it's working only on the ventricles. The other antiarrhythmic, very common one that we use is called amiodarone. Right,
Okay.
and amiodarone works on sodium and calcium channels, and it works on both the atria and the ventricles.
Okay.
So it suppresses all of that, right? So it's a very useful drug. But now I recently did a PULS pediatric advanced life support course, and they were emphasizing lignocaine. They were saying, look, nowadays we're using lignocaine for everything, actually better, right? Because lignocaine only works on the ventricles, so it's not suppressing the entire heart.
Okay.
So also you give these drugs for refractory VFib when you're resuscitating somebody and the heart's going crazy. It's in ventricular fibrillation. The electricity is just going everywhere.
Giving them a
and
couple.
shocking, and it's not working. The shocks aren't working. You give them an antiarrhythmic. The old guidelines were to use amiodarone. Now they're saying actually rather use lignocaine because it's just working on the ventricles, not suppressing the entire myocardial. Yeah. That is a bit of an argument that is not, although it is still okay and recommended to use amiodarone for refractory ventricular fibrillation, but it makes sense while we're using these drugs.
Yeah.
So basically, it's important to understand that your whole body works just off its electrolytes moving, cations and anions that are moving. Even drugs that affect mentation, like benzodiazepine, for example, what it causes is a chloride shift. I can't remember whether it's into or outside of the cell, and makes that cell less sensitive to being triggered, right? The stimulus, the action potential, they call it. So even a sedative, a drug that you take that makes you feel drowsy, is working on electrolytes. Interesting, eh? So we can get more into that. And for athletes, acid-base balance and fluid electrolyte and acid-base balance is really important. And so it's really important if you want to understand what's happening on a cellular level. You've got to understand.
There's research to be done.
Anions and cations, and in the heart, that's what's happening as well. But we're going to get more into Cole's PVCs. The interesting stuff that there is a couple of things that are interesting stuff that I wanted to read about. Just saying the evaluation of PVCs and talking about symptoms, understanding PVC location. Okay, and there's a lot of stuff that we're going to bring up for you, and the prognosis, etc., etc. Let's just look at the other. Pills comes from. I don't know what books this comes from, but it comes from Stat Pills. Okay, and basically this is the National Library of Medicine, and it's talking about premature ventricular contraction. It says during a PVC, the heartbeat is initiated by the Purkinje fibers, which are down in the heart, rather than the SA node, which is your heart's pacemaker. Given that a PVC occurs before a regular heartbeat, there is a pause before the next regular heartbeat. PVCs can occur in isolation or in repeated patterns. 2 consecutive PVCs are termed doublets, while 3 consecutive PVCs are named triplets. You didn't have consecutive PVCs, you just had 6 in a minute or whatever that. So it's important to note that 3 or more consecutive PVCs are classified as ventricular tachycardia, okay, VTAC. This activity describes the pathophysiology of PVCs and stresses the importance of the interprofessional team on its management. The risk with the PVCs is that if they're in strings, it can turn into ventricular tachycardia, which is a pre-arrest rhythm, which is where your heart is just being initiated or triggered to beat by the ventricles, and it's just PVCs, which is VTAC. Your heart can't fill properly. Your heart's output or the stroke volume or ejection fraction is decreased, and death. And they say that arrhythmias or pre-arrest condition is about 90% of cardiac arrests. I think from what I last heard is the cause is an underlying arrhythmia like this, pre-arrest rhythm, right? So does it make sense if you have more than 3 PVCs, then it's a ventricular tachycardia.
Then your whole ticker's kind of gotten thrown out of sync, and it starts to.
That's the worry, is that
fix itself.
PVC is triggered and then carries on.
It carries over to keep you alive, basically.
But basically, you're going to die because it's a ventricular tachycardia.
It's its last effort.
Yes. Yeah. If it's not. So objectives: recall causes, describe workup, summarize treatment options, explore modalities. Introduction. We've been through the heart's intrinsic conduction system. Etiology: in the vast majority of cases, PVCs have known cause and occur spontaneously. Common known etiologies or cause include excess caffeine, excess catecholamine. Catecholamine is adrenaline or basically adrenaline or something, a neurotransmitter that's responsible for the sympathetic nervous response. High levels of anxiety and electrolyte abnormalities. Specific electrolyte changes found in those who experience PVCs are low blood potassium, low blood magnesium. Magnesium is another cation, positive ion, anion. Can't remember. We'll fix it in the description. And high blood calcium, alcohol, tobacco, and illicit drugs also associated with PVCs. Patients suffering from sleep deprivation also experience PVCs, and there are also numerous cardiac and non-cardiac pathologies that are causative of PVCs. Examples include cardiomyopathy, mitral valve prolapse, mitral or myocardial infarction, which is a heart attack, any structural heart disease, okay, can do it. Non-cardiac examples include hypothyroidism, anemia, and even hypertension. Patient populations with high risk of cardiovascular disease and clinically poor cardiovascular markers have a high occurrence of PVC. So, risk factors for PVC include advanced age, male gender, hypertension, African American, hypomagnesemia, which is low levels of magnesium, bundle branch block, which is a block in the intrinsic conduction system of your heart, and indicative left bundle branch block of an or heart attack. But anyway, that's a bit more complicated. Hypokalemia, low potassium, and underlying ischemic heart disease. But it says here, PVCs are common among the general population. The estimated prevalence ranges from 1 to 4% on ECG and 40 to 75% on a 24 to 24-hour Holter monitor. Young and healthy adults have shown a high, similar frequency rate of PVCs, in contrast to the older segments of the general population. It's common. Okay, so pathophysiology, so we've already been through this. Okay, history and physical evaluation. Okay, there's a whole bunch of notes on the evaluation, and then there's a grading system for PVCs. Treatment and management we've been through, and then differential diagnosis is something else that's happening. So it could be a premature atrial contraction or PAC, which is how you tell the difference looking on an ECG is QRS complex is wide or narrow. So if something that QRS, we'll get into an ECG. We should actually do a whole episode on ECG.
And the results.
Yeah, but basically what you're looking for, if it's atrial, if it starts in the atria, then it's a narrow complex. If it's wide, if it starts in the ventricles, then it's a wide complex.
And that's the difference between
atrial and ventricular contraction.
What was that abbreviation you said? A CPA? PAC.
Yeah, premature atrial contraction. Yeah.
Okay.
So that we've been quite a lot onto PVCs. I'm going to share a study with you from the Journal of American College of Cardiology, which is ventricular ectopy as a predictor of heart failure and death. Right. I think with you it's benign. I think the doctor also was happy that it was benign.
He didn't seem concerned. I think he just wanted in case. And then they get a cardio.
Basically, what the cardiologist will do is the cardiologist's own investigation is probably going to be an echo, where they book you for an echo and they start seeing what's going on in your heart, and like I said, also bloods as well. But I mean, it's up to you if you want to see the cardiologist. Maybe not right now. Maybe you want to see them in the future.
Yeah. Definitely in the future.
Yeah.
I don't know. Got no sponsors, got nothing yet. So
we get in there.
It's cash out of my pocket.
Yeah, we get in.
So we'll get there. Yeah, we're going to get there.
Another thing that we chatted about was your inguinal hernia, but we'll do a whole. I've had it 3 times repaired, my inguinal hernia. Since maybe even 4 now. I've had it 3 times repaired.
The doc even said it could have been there well before I had noticed it and even diagnosed it. And so we'll see. I don't know if it's going to be a big problem now. I'm just going to carry on lifting heavy.
Be a problem for you right now. Yeah.
I'm going to carry on lifting heavy because I can't let it affect every workout that I'm doing. So we'll basically wait to see what happens. If it gets any worse, if I feel any pain, if it starts to get strangulated or anything, then I'm going to go. It's going to be an op.
Interestingly, like the doctor said, it's the small ones are the ones that catch out, because the small ones are easy to get incarcerated or trapped by the muscle. The big ones kind of just move in and out, like he said. But the small ones are the dangerous ones. Yeah. Having said that, I've also had exactly what you have, but mine was all right-sided inguinal hernia. Like I say, repaired 3 times. On the 3rd repair, a Russian trauma surgeon did it, and he told me, he said the surgical technique that he's used won't come apart, and it hasn't. I've had
How long ago was that? When was that?
10 years ago.
10 years ago. Yeah.
10 years ago.
Was that the last op you've?
That's the last op.
That's the last one.
I've never had a problem since, and I've put my body under huge
And
load.
the other two that got fixed?
It was old surgical techniques. So it was.
So did they like reoccur? Did they?
Yes. Yeah.
Damn. Okay.
But yours won't, because they're going to use that modern
use the new
technique
techniques,
to do it. So they're going to use the new technique to actually do it.
Yeah.
No,
I'll tell them, listen, I'm a weightlifter. This thing's going to be pressurized.
Yeah. And this is important. We should do an episode on inguinal hernia, and we should go through how you can actually diagnose yourself. Even for males, look, women are all over it. They're all over their mammary health, and they're all over. There's a lot of awareness that's put into women actually doing a self-check on their mammaries. Yeah. We want to do the same for men. Yeah. We want to actually we should bring in the testicular check and let males be able to do their own testicular check. It's really important.
Yeah. I mean, you don't want to be stuck with testicular cancer. I mean, that's like the worst thing, and probably
we've been going
worse things, but
No, you don't want that.
No.
But it's important. We need to. Nobody's talking about
it. Diagnosing yourself.
Yeah. And it's November, guys. He's got his Mo. I don't, but I'm with you guys. And we're celebrating November and what's November about? It's about men's testicular health, basically. So this is actually a good month that we're dropping this in November, and we should talk about it. Yeah. We'll do a whole episode on it, on checking your own, checking yourself, doing a testicular check on yourself, and and we'll also bring up a follow up on
everything. On our blood. The next episode will be.
It's going to be the
more in depth, but also interesting, because I think we'll do like a maybe when we get the results back, our first episode will be more broad, because it'll be like taking a look at everything, and then from there we have so much to go into for you guys. So it's really, really cool. There's tons of episodes we can pull out of that.
And can I touch up on the last episode quickly?
What was it?
So just to touch up on the last episode. So just to tell you guys. So I got a little bit tongue tied. Korotkoff sounds.
Oh, with the Korotkoff.
Yeah, Korotkoff sound is okay. Look, when you're listening, when you're using the auscultatory method to test somebody's blood pressure, to take their blood pressure, when you hear the blood rushing through, and you hear the first sound, that's your systolic, right? There are a couple of other Korotkoff sounds, but where sound is lost, that is your diastolic. So I just want to break it down. So these are Korotkoff sounds are broken down into 5 phases.
Yeah, we just for the views, we are going back from that first episode. And this is just the Korotkoff sounds was how you listen when you're taking the blood pressure.
Yes.
Okay, cool. Just wanted to put that out there.
Because I was a bit wishy-washy in it. But anyway, phase 1 is clear tapping sounds heard for at least 2 consecutive beats. This is the systolic blood pressure. So you've got your cuff on, you've pumped it up, you've done your palpated, you pump up a little bit past that, you're listening now, and you start deflating the cuff, and you hear tuk, tuk. The first one, that's your systolic. That's where you heard it, right? Then you get phase 2, which is the softening of the tapping sounds and the addition of a swishing sound, right? Then you have phase 3, which is the return of tapping sounds as heard in phase 1, but with an increase in sharpness and intensity. And then you have phase 4, which is the abrupt muffling of sounds, exhibiting a soft and blowing quality. The muffling sounds is explained by increased resistance of the artery to collapse, caused by downstream engorgement of the veins. Engorgement is filling. Then you have phase 5, which is complete disappearance of all sounds. This is the diastolic blood pressure. In reality, when you're when you're actually taking somebody's blood pressure, you might hear none of that. Sometimes when I'm taking Cole, I just hear it come in, the systolic coming, and then it just goes away, and then it's a diastolic. Other times there's a bit of a pitch sound, and you can hear these other swooshing sounds and so on. But the important thing to note is where you hear the first sound, systolic. Where the sound disappears, diastolic. That's the important note.
That was the little correction. What did you say last week? You just said that when it fades off, I
used it wrong. I said pitch change, but I was meant to say when there's no more sound. And also I didn't really go into Korotkoff sound, so I just wanted to go into it. Even though we shared the study, maybe you want to hear a nice explanation from it.
Yeah.
And then just with regard to stethoscope anatomy. So if you're looking at a stethoscope on the end here, traditionally, this big part, the white part, is called the diaphragm, and the small part is called the bell, right? So traditionally, the small part, the bell, is for listening to low-pitched sounds, and the diaphragm is for high-pitched sounds. This Littman Classic, though, works on pressure. Both are basically diaphragms, and I can turn it like this to either listen from this one or listen to that one. There's a click, right? On this stethoscope, gentle pressure, so I'd use the big side for an adult, I'd use the small side for a little baby or pediatric. If you use gentle pressure, you can hear low-pitched sounds. If I put a bit of high pressure down, I can hear high-pitched sounds. Although this Littmann does come with the attachments, you can take this off and you can convert this into a traditional bowl where you use it for low-pitched sounds and then you use the diaphragm for high-pitched sounds. Okay. But that was basically just stethoscope anatomy. And then if you take a look at these earpieces, they must be pointed outwards like that. If I wear the stethoscope like this with them pointed in, I'm just blocking off my ear canal. There's no sound can be because your ear canal's like that. So you see there's a bit of a curve there like that, and they should be pointed in that direction. And that was just stethoscope anatomy for you guys. It was just something that we went through. We are going to be bringing an episode on electronic blood pressure monitoring and everything else, so stay tuned for that. And I think we're done for now. Otherwise, we could also have another episode where we'll get into his supraspinatus tendonitis that Cole has. Might be common for a lot of you out there, and that's just
I think it's definitely common. The doc did a little physical exam, and the one thing, you guys can do it now if you have someone with you, if you train as well and you're doing a lot of overhead pressing, bring your elbows up to a nice 90 degree like this, palms facing out, and then you basically get a friend to pressure and just hold you, and you try to pressure up. And if you feel any pain in your shoulders,
supraspinatus tendonitis, inflammation of a tendon, inflammation of that supraspinatus.
Could just be from lots and lots of heavy presses. Also pressing in one direction. So when we're in the gym, we're pressing up, and this is such a complex joint. There's a lot of other angles involved. So when you're building muscle one direction the whole time, you try to put some load on in another direction where you actually haven't built those fibers in that correct way and loaded it in that way. That's when you get the pain and you get some things going on. So anyways, future episode on that. I think we'll finish off with our blood pressure.
Yeah, let's do it.
So we'll take our kind of weekly reading for you guys, just if you are interested.
Cool.
We'll get on to it now.
Okay, so we've had Cole sitting for a period of 5 minutes, completely relaxed. His elbows are at his heart's level and his feet are uncrossed. And now we're going to go ahead and we're going to check his blood pressure and take your watch off. Right? So what we're going to do, like we always do, I'm just going to get a palpated systolic blood pressure. So I'm going to feel his pulse. I'm going to pump up until it disappears. Slightly elevated, 140, but remember we're going to get 2 and average them. And it's a different time of day. We're testing now at, what's the time now? 1:40. Last time we were testing at like 4 o'clock in the afternoon. So there's already a difference in the timing. Okay, let's do this. All right, now that I've got his systolic palpated, let's just get another proper reading. Trying to be perfect as we can about it. So remember that I'm watching the marker. So this left arm, his left artery should be there. So let's go ahead. Okay, so this first reading is 140/80. So we're going to get you to sit still for a minute, just like that. And then we're going to get another reading. Remember, if they're close together, average them. If they're not close together, take 3 sets and then average those. (145/80). So what we can say is that we can average that out. We can say that it's like 142.5/80, which is a little high. 130, 140 or higher is high blood pressure, hypertension stage 2. Yeah. 140. Stage 1, yeah. But you're not having any acute symptoms or anything else. It's probably just a normal fluctuation. Your average has been low before, which is quite good, even when you're in the doctor. So this might be a time of day. Maybe he's a little bit stressed or something right now. Something's happening. We don't know. Remember that your heart and your cardiovascular system is also a slave to hormones and a slave to your sympathetic nervous system and all the rest of it. Oh, there we have it.
deep breaths and take your mind off of something, and you can actually bring it down a little bit.
Yes.
I tried that, but didn't work.
Okay, cool. All right.